Thank you, Dr. Balaji, Dr. Virmani, for kind introduction. Dr. GVK and the entire team of 3D-Con for inviting me to speak on this subject, which is something different from the routine subjects that we dwell upon in diabetes conferences, that is statin-induced diabetes, realities and risks. So this is the clinical dilemma. We all know that statins, they are the cornerstone for cardiovascular event prevention or ASCVD prevention. There is a growing clinical evidence that statins, they are associated with increased risk of incident diabetes or new onset diabetes. So let's find out whether the risk of new onset diabetes is high enough so that we need to worry about statin use in people who are at risk of diabetes or who are already having diabetes. So this is the recent meta-analysis which clearly shows that of all lipid-lowering agents, statins are the agent which provide 3-point MACE reduction, CV mortality benefit, and all-cause mortality for overall cardiovascular disease prevention in all category of patients. And if we go for primary prevention, then statins are the only molecules that provide 3-point MACE reduction, CV mortality reduction, and all-cause mortality reduction. This is based on large analysis of most of the randomized controlled trials with statins across the globe. But the first trial which gave signal that statins can promote dysglycemia was the Jupiter trial. The randomized double-blind trial, 17,000 men and women without prior cardiovascular disease or diabetes. They were either given rosuvastatin 20 milligram or placebo, and then they were followed for a period of 5 years. The primary endpoint was myocardial infarction, stroke, hospitalization for unstable angina, arterial revascularization, or CV death. So that is an extended 3-point MACE. And there was a protocol for pre-specified secondary endpoints, and that included venous thromboembolism, all-cause mortality, and also first time they touched upon this new onset diabetes or incident diabetes, whether statins they are linked with that or not. And if you see this data, this is about incident diabetes, the first block, and the second block is about cardiovascular event reduction. This is the patients who were having no major risk factors for diabetes at baseline. The risk of incident diabetes was not increased. That was 0.99 hazard ratio, and it was not statistically significant. But the people who were having one or more major risk factors for diabetes at baseline, the risk of new onset diabetes or incident diabetes was increased by 28%, and this was statistically significant. And if you see the cardiovascular event reduction, they were equivalent, whether the patient was having no risk factors for diabetes or one or more risk factors for diabetes. So cardiovascular protection is there across all the patients, but those who were having one or more risk factors for diabetes, they developed diabetes, the risk increased by 28%, and that was statistically significant. And this was dependent on the fasting plasma glucose. As the fasting plasma glucose increased above 110, so those who were having impaired fasting glucose, they were at higher risk of developing diabetes with statin therapy in Jupiter trial. And they concluded that in trial participants with one or more risk factors for diabetes, if you use statin, there will be a 39% reduction in the primary endpoint, 36% reduction in venous thromboembolism, 17% reduction in total mortality, and 28% increase in diabetes. As compared to placebo, statin accelerated the average time to diagnosis by 5.4 weeks. So those who are at the verge of developing diabetes, it will occur early if you put them on a statin therapy. In this case, it is rosuvastatin 20 milligram as per the Jupiter data. Still, they concluded that among those with and without risk factors, the statin impact on vascular events were greater than the hazard for developing new onset diabetes, and therefore they concluded that statin should be continued along with all other parameters for cardiovascular prevention in people who are having high cardiovascular risk, irrespective of whether they develop or do not develop diabetes. Then came this meta-analysis by Naved Sattar, published in Lancet, 13 statin trials, more than 19,000 participants. Odds ratio with statin therapy was 0.9, that is 9%, with little heterogeneity between trials. And they concluded that this was more in people who were older, but it has got no relation with baseline BMI, as well as the change in LDL cholesterol concentration. That means the potency of statin was nothing to do with the development of diabetes. It was associated with 9% increased risk. So if you treat 255 patients with statin for 4 years, that will result in development of diabetes in 1 extra case. So this is negligible. And another trial from the NTT and the stroke prevention by aggressive reduction in cholesterol levels trial, they also concluded that those who are having hypertriglyceridemia, those who are having pre-diabetes, if you put them on statin, then they are at much higher risk of developing diabetes as compared to those who are having normal fasting glucose and normal triglyceride levels. So the people who are already having metabolic syndrome, the features of metabolic syndrome, they are at high risk of developing diabetes with statin therapy. Does it change with the intensity of statin therapy? This is meta-analysis where they have tried to compare moderate dose statin therapy and intensive dose statin therapy and their impact on incident diabetes and incident CVD. We all know that the intensive therapy provides 16% more reduction in cardiovascular events as compared to moderate intensity, and at the same time, the diabetes risk is increased by 12%. So higher intensity is associated with more risk of development of diabetes, new onset diabetes, that you have to keep in mind. As compared with moderate dose statin therapy, the number needed to harm for intensive dose was around 500 for new onset diabetes, and at the same time, if you use in 500 patients, you will result in 1 new case of diabetes. At the same time, you will prevent 3 cardiovascular events. So it is much more beneficial than the risk of new onset diabetes. Does the type of statin matter as far as this dysglycemia or diabetes risk is concerned? So let's compare the statins. Pravastatin, which is hydrophilic, which is neutral, and it has shown some protection in Voskop's trial. Pitavastatin is lipophilic. It is neutral data, or Japanese trial is available where in people with IJT, pitavastatin was associated with no bad impact on glucose outcomes. Rather, there was a reduction in fasting glucose and HbA1c. Atorvastatin, there is a dose-dependent increase, and rosuvastatin, there is a dose-dependent increase. So the 2 statins which we routinely use in practice, that is Atorva and Rosuva, they both are having dose-dependent increase in diabetes risk or glucose when we use it either in non-diabetic individuals or diabetic individuals. So how statins they contribute to diabetes? Is it because of their impact on HMG co-reductase enzyme? So they have tried to find out various variants of HMG co-reductase, that polymorphisms which are associated with decreased activity of this enzyme, and they have proven that those who are having these polymorphisms, they are having lower LDL cholesterol, but at the same time their BMI is high and the risk of developing diabetes is high. So there is some relation with HMG co-reductase enzyme and the risk of development of diabetes, and the evidence suggests the link is a direct result of enzyme inhibition and not off target, and it is class. All statins work through HMG co-reductase and therefore they increase the risk of new onset diabetes, and this they have proven. This is the meta-analysis of randomized control trials related to statin, and they concluded that LDL will go down by 0.92 millimole per liter. There will be an increase in body weight by 0.24 kg, and the odds of new onset diabetes will increase by 12%. This is one of the large meta-analysis related to statins. And they also tried to correlate it with population-based studies, where they have tried to find out the HMG co-reductase polymorphisms, which I have already highlighted. And they have shown that the same way, those who are having HMG that enzyme polymorphisms, the risk of diabetes is increased by around 8 to 10%. So same like statins, where it is 12%, here it is around 8 to 10%. So one of the mechanisms why statins induce diabetes is explained by this inhibition of HMG co-reductase enzyme. inhibit this enzyme and you increase the risk of diabetes. There is some impact on the pancreatic beta cells. We all know that statins are transported into the liver through this transporter that will result in increased expression of LDL receptors and consequently higher absorption of LDL cholesterol into the liver, and the serum LDL cholesterol will go down. At the same time, the receptors in pancreas, they are also increased, and therefore higher amount of LDL will go inside beta cells. That will result in lipotoxicity, and that will result in decrease in insulin secretion, and that may contribute to the development of diabetes. So this is one of the direct effects on pancreatic beta cells through LDL cholesterol receptor overexpression. Also, it can result in blunting of L-type calcium channels that will reduce insulin release from the granules. Mevalonate pathway that will reduce this synthesis of isoprenoid, and that will inhibit translocation of insulin vesicles. And coenzyme Q10 depletion, which occurs with statins, can have mitochondrial dysfunction, and that will also contribute to the beta cell dysfunction and development of dysglycemia. Also, it has got impact on insulin resistance. There is GLUT4 downregulation, so uptake inside the adipocytes and skeletal muscle cells will go down. There will be a signal interference that will blunt insulin response, and there will be a decrease in adiponectin and other beneficial adipokines that are associated with improvement in insulin sensitivity. So these are the various mechanisms on liver, on beta cell, on muscle cell, on adipocyte, through which the statins, they increase the risk of development of new onset diabetes. And also there is some role of microRNAs, and this is an upcoming field of research, but there is a lot of evidence that statins can increase the risk of new onset diabetes. There is role of gut microbiota also. This is a recent animal study reported in 2024 where statins, they alter gut microbiota, that bile acid metabolism, mainly the decrease Clostridium, as a result of which the GLP-1 will go down, and that will also contribute to the development of new onset diabetes or hyperglycemia. And if you supplement them with UDCA, then this may prevent the decrease in this gut microbiota, that is Clostridium, and that can decrease the hyperglycemia which is being induced by statins. This is one of the animal study data. What about diabetes? These are various trials. This is network meta-analysis. A1C can increase by 0.11% with statin, mean increase of 0.63 with high intensity atorvastatin. In Australian study, low intensity statin, no change, moderate intensity, 0.22% increase in A1C, high intensity, 1.05% increase in A1C. And the same has been reported from US by Sukhiza et al. This is a trial from Turkey where they have tried to find out the impact of statin on glucose, fasting, as well as HbA1c, SKID study, and where they have used either atorvastatin 20, rosuvastatin 10, or pitavastatin 2 milligram, and they concluded that if you see the fasting, it is not much altered, but HbA1c is marginally increased by rosuvastatin, that is 0.2%, but pitava has reduced A1c by 0.75%, and the HDL cholesterol increase was significant with pitavastatin. So this is one data from Turkey which says that pitavastatin fares better, and it can reduce A1c, and it can also increase HDL cholesterol in addition to reduction in LDL cholesterol and triglycerides. And same has been proven in one of these small studies where atorva 20 to 40 was compared with pitavastatin, and as you see, this blood glucose rise 7.2% with atorva and 2.1% with pitava. So pitava may fare better as far as the dysglycemia is concerned. However, this meta-analysis of randomized controlled trials concluded that there is no difference in fasting, A1C, or diabetes onset with pitava versus other statins. However, a non-significant trend favored pitavastatin over the long term. Therefore, pitava you may consider in people who are at high risk of developing diabetes and who deserve statin therapy. What else can you use? You can use ezetimibe. It has got negligible impact on glucose. PCSK9 inhibitors, particularly in high-risk patients. And bempedoic acid, probably it has got some beneficial effect on insulin metabolism as per clear outcomes. So you need to think of before starting statin therapy, you measure fasting and HbA1c, identify people who are at risk, reevaluate A1C within 3 to 6 months. If they develop diabetes, do not stop statin. If they require statin, continue statin therapy and put them on glucose lowering medication which provides additional cardiovascular risk reduction. To summarize, I will say, people in which you are considering statin therapy, do baseline risk stratification by measuring their fasting plasma glucose and HbA1c. If you put them on statin, emphasize lifestyle interventions that will benefit not only in reducing cardiovascular events, but also in reducing or preventing the development of diabetes, which will occur early with the use of statin therapy. Aggressive lipid control is the priority as far as ASCVD prevention is concerned. If diabetes occurs, then treat it, don't stop the statin. Consider pitavastatin or low-dose atorvastatin along with ezetimibe in people where you want to achieve very low LDL cholesterol, particularly if they are at risk of developing diabetes or pre-diabetes they are already having. So to conclude, I will say this quote, there is something bad in everything good and something good in everything bad. Thank you.